Welcome to this medicine masterclass in which we will be discussing the importance of effective communication. We will cover the approach to the patient, the personal and professional obligations, the weight given to the consultation environment, key communication skills, history taking, and systems review. The clinical environment sets the scene to establish the rapport and gain history from the patient. The environment must be comfortable and adequate to the consultation. Each scenario may require a different environment. An emergency where a patient has been brought in by ambulance following a serious car versus bike accident would be different to the environment that you would consult a young female concerned about a breast lump, and may be different to a meningitic patient who would like a darkened room. Or consider an elderly man who's become confused and aggressive on the wards and is throwing things at other patients and staff. The environment would need to be adapted to help facilitate this patient. So a patient who's come in following a road traffic accident which is life-threatening would require a resuscitation room, a large area around the bed space which can allow a multidisciplinary team to be present, as well as a cardiac arrest team in case the patient deteriorated. The environment should be close to the MRI scanners, the CTs and the theatres. Whereas a young female concerned about a breast lump would require a private environment with the presence of a chaperone, the door closed where other people are not coming in and out. A meningitic patient would want a quiet, darkened room. Whereas an elderly patient who's become delirious would necessitate a familiar environment, maybe with the presence of security personnel, and minimize the changeovers of staff. Consider this case. A married man presents to your clinic and he's accompanied by his wife, concerned that he's contracted AIDS from unprotected rectal intercourse with another man. He's the breadwinner for his household and he's adamant that his wife will leave him if she discovers that he is unfaithful. Here, there are many things that go into the consultation environment. There is the sensitivity, the honesty, the probity, but also the deeper respect of the patient, where he would want this to be a confidential discussion, and it takes effective communication skills to be able to ask him to be alone in this environment. However, deeper than this is an ethical issue of should the wife be informed. She could contract HIV from him if this information is not disclosed to her, even though the gentleman is adamant that his family will break up. Moreover, if the wife is present, the man may not disclose his entire clinical issues. The environment, if it is not private or quiet or well lit, may also impede communication. How would you gain consent to have the wife present, or how would you ask the wife to leave? These are things to think about. First of all, there are our professional obligations. We need to ensure that we have the adequate knowledge, skills and clinical acumen, a kind attitude towards the patient, to act with compassion and empathy, and to respect confidentiality except in very specific circumstances. Our dress and demeanour should demonstrate respect for our patients, relatives and our colleagues. Hand washing and cleanliness is an important prerequisite. We know that transmission of microorganisms from the hands of healthcare workers is a major source of cross-infection in hospitals. Hand washing is an effective way to prevent spread of infection. Wash hands before each patient and during consults if required, and afterwards too, and this can help reduce the transmission of infections such as MRSA, C. difficile, Salmonella, E. coli, Shigella, norovirus and RSV. Let's focus on the key communication skills. Start by thinking about your posture. How do you feel if you were a patient and you need to convey something deeply private and your doctor is sitting like this? you wouldn't feel very comfortable. And so, suffice it to say, the non-verbal aspect of our communication can be as important as our verbal communication. It's important that we demonstrate interest and respect our patients. We empower them to ask questions, empower them to seek clarifications on any terms or questions that we ask. Allow the patient to complete sentences. Sometimes, through habit, we can think we know what the patient wants to say, or we are, through their few sentences, understand the trajectory of the clinical case, but it's important that we allow patients to complete their sentences. For some patients, the pace of communication and pace of consultation needs to be significantly reduced. Consider Parkinson's patients who have slow movements, bradykinesia. The patients need to have confidence in our ability to engage them. Consequently, emotional intelligence is important. Patients will open up about very deep issues, and it's important that we avoid jargon. Even if your patient is a medical professional, it's still important to recognize that under the stress of them being a patient, they may not be able to comprehend jargon. The tone of voice used should be one that demonstrates empathy, interest, and respect, and appropriate to the consultation. Non-verbal communication skills also include good eye contact, active listening, comforting the patient appropriately, providing time for the patient to express feelings on difficult topics, and allowing them to expound on these topics. An appropriate silence with the appropriate posture and gestures is important to allow the patient to understand that you're listening and processing what they're saying. Nodding and relevant facial expressions reflecting the conversation are also useful in transiting the discussion. You should be actively picking up on verbal and non-verbal communication clues given by the patient. If the patient suddenly stops, or suddenly looks down or looks away, maybe you need to enter that discussion in more detail because there may be vulnerability or a safeguarding issue. But this requires sensitive probing. As you go along, make interim summaries to make sure that you're comprehending appropriately and the patient has communicated all the key things that they want to. Avoid multiple questions, as this can be difficult to answer, and make empathetic statements and avoid being judgmental and show warmth. Your posture, body language can demonstrate your interest and enthusiasm. A good thing to think about is if you're in a cinema and you're completely engrossed in the movie, you're not aware of whatever else is happening, this is how you should be with your patient, where they're the absolute center of your attention. Non-verbal communication skills also include avoiding the use of personal mobile phones, looking at your watch, which may distract the patient or make the patient feel that you're too busy for them, and that could preclude or prevent an effective consultation. The way that we smile or approach needs to be appropriate. Take this consultation. This may be perceived to be too much and may make the patient uncomfortable. And this expression may be too serious or too intimidating. So it's a matter of reflecting your patient and following what they need. Let's come on to the history itself. Once the appropriate environment has been established, introduce yourself with your name clearly, define your role, and explain the purpose of the interview. Explain what team you're from and what you aim to ascertain. Ensure you have the correct patient by taking their details, their name, the age, their date of birth, and determine their source of referral to you. Always confirm that the documentation that you are using or referencing is about the correct patient. In the history, start with a presenting complaint and then the history of the presenting complaint, followed by a systemic review. After the systematic review, inquire about past medical and surgical history, drug history, and whether they have any allergies. Move on to a family and social and occupational history, as well as a travel and sexual history. You may need to ask and perform a mental state examination and inquire about the patient's ideas, expectations and concerns, and throughout perform interim summaries and then formulate differentials, investigations and a management plan, and ensure that you're not only dealing with the clinical issues, but you're also addressing the concerns of the patient. So the presenting complaint should be an open question. May I ask what has brought you to the hospital today, or why have you come to the hospital? Allow the patient to freely talk and explain, as this is where they're most likely to be open. The history of presenting complaint is there to allow you to dissect each factor of the presenting complaint and the history to gain more detail. So if the patient reports pain, it's for you to inquire and ensure you know the site, onset, character of the pain, whether there's radiation, any associated features, when that pain is coming, what makes that better or worse, and the severity score. And we use the acronym or mnemonic Socrates to help with this. Following the presenting and history of presenting complaint, ask about any other problems that the patient may have. Ask about general questions such as weight loss, which may indicate malnutrition, a loss of appetite or malignancy, weight gain, which can also be as a result of hyperphagia or other clinical diseases, or maybe as a result of depression. Ask about night sweats, which may indicate occult infections or malignancy. Fevers, which may indicate infection, abscesses or neoplasia, and whether the patient has fatigue. This may be as a result of clinical conditions, including anemia, heart failure, neoplasia. Ask about difficulty sleeping. This can sometimes help elucidate any psychological problems, chronic pain, or any change in the patient's voice. Asks about cardiac symptoms, chest pain, to determine whether or not the patient may have angina or an ACS, shortness of breath, particularly on exertion, that may suggest the heart is not pumping as effectively. Ask about paroxysmal nocturnal dyspnea. This is where a patient wakes up gasping for air at night, and this is because as they lie flat, fluid builds up on the lungs as a consequence of heart failure, and the patient has to wake up to allow that fluid to redistribute to the bases of the lungs so that there's some aeration and the patient can breathe properly. Orthopnea is a compensatory mechanism to help prevent this, where the patient props themselves up on some pillows to keep themselves relatively upright, and this may suggest underlying heart failure. Ask if the patient's noted any edema, swelling of their limbs, and if so, to what extent. This can be cardiac, can be renal, or as a result of liver disease. Ask if the patient experiences any palpitations or syncope or presyncope, and this may be as a result of arrhythmias, which can be frequent or paroxysmal. Inquire about calf pain or ulcers in the legs or feet as a result of poor vascular circulation or the development of blood clots. Move on to asking about respiratory questions. Again, shortness of breath may be as a result of respiratory disease. Ask about a cough. A persistent cough that's going on for a period of months may require investigation for sinister features. Ask about wheeze, which can be related to asthma or COPD. Importantly, ask about daytime concentration, irritability, and how good the patient's able to sleep, because obstructive sleep apnea may cause the patient to have very poor quality sleep. Hemoptysis and night sweats may indicate malignancy or tuberculosis, and chest pain, pleuritic in particular, could indicate underlying sinister pathology. Neurological system review, ask about headaches, weakness, loss of sensation, any fits or seizures, altered consciousness, dizziness or balance problems, which would help you determine whether there's any underlying neurological conditions. When reviewing the abdominal system, inquire about acid reflux, abdominal pain, diarrhea or constipation, any problems with swallowing, whether the patient is nauseated or vomiting, and whether there's any altered stool habit. In particular, ask if the stool has changed colour or if there's any blood present, Ask if they've noted any abdominal distension or yellowing. Genitourinary system questions, the mnemonic fundish can help. Frequency, are they going to the toilet a lot? Urgency, do they need to go very quickly? Nocturia, are they passing urine at night? Dysuria, do they have any pain passing urine? These things can indicate urinary tract infections. An intermittent stream or strangury may suggest bladder outflow obstruction, and hematuria can be as a result of infection or even malignancy. And ask about any lower abdominal pain. Ask about the visual and hearing system. Any changes in visual acuity may be as a result of diabetes or ocular disease or neurological disease. Ask if the colour vision is affected, short or long distance, whether they've developed any blurry vision or eye pain or redness, which would require further investigation. Ask about hearing loss, ear discharge or balance problems, which could indicate vestibulocochlear pathology. If in female patients, take an obstetric and gynaecology review, asking about any breast pain, lumps, nipple discharge or changes in the nipples. Ask about the menstrual history, any previous pregnancies, deliveries, and whether there were any complications. Ask about vaginal discharge or therapeutic or spontaneous abortions. These are very intimate questions and would require signposting and the presence of a chaperone. Asking these questions with the presenting complaint and history of presenting complaint would allow you to gain a very detailed history about what's brought the patient in. Now contextualize these in the context of the patient's past medical history and past surgical history. If there are any previous conditions, ask about interventions. So if the patient says they have heart failure, ask when was this diagnosed, what has been done about it, who looks after them, which cardiologist, and whether there are any recent clinic letters. If the patient reports angina, say how long have they had that? Have they been to their GP? Has the GP referred to a cardiologist? What have they been prescribed? If it's isosorbide mononitrate, is the dose adequate? Have they had any definitive or detailed investigations like an angiography or an echo? As this would allow you to start managing from that point. If the patient mentions any surgeries, ask about the interventions and whether there are any complications from the operation or from the anesthesia and whether they're waiting for any further operations. Next, move on to ask about the drug history. Not only is it important to make a note of what medications the patient's on, it's very important to ask about the indications and compliance. The dosages and the frequency and whether these doses have been recently titrated, and ensure that the medicines that they're on are appropriate and there's no polypharmacy. As well as prescribed drugs, ask about over-the-counter medications, contraceptive pills or homeopathic medications. Ask about any vitamins. In particular, ask about anticoagulants. Conventionally, when patients were treated largely with warfarin, they were very aware of this due to regular INR checks, as well as clinic appointments with the anticoagulant nurses. But now with NOACs or DOACs, which don't require routine monitoring, sometimes patients can inadvertently forget to mention they're on an oral anticoagulant. And this is very important, particularly if you need to do a procedure and you need to hold the NOAC. If the patient reports any allergies, ask the nature of the allergies, when they had this and what the specific reaction was. If the patient just makes a generic statement like I take some red tablets, then don't assume you know what that tablet is. Ask them if they can show you the packet or whether they have a prescription with them. Sensitively ask about family history. Are there any illnesses or genetic conditions, particularly in first-degree relatives? Establish whether conditions exist on the maternal or paternal or both sides, and if positive, check at least 3 generations if the patient has access to this information. Inquire about early deaths as well as consanguinity. Remember, if patients report conditions in their family, you should offer empathy and explain that you are sorry to hear if their father, mother, brother or sister had an early death or have been affected by a condition. The social history has a number of components. Ask about the occupation. Sometimes the occupation of the patient can impact their health. Occupational asthma tends to improve on weekends or days off. Smoking history, ask when did the patient start. Any increments and Points of increments can point to stressful points in a patient's life. Ask them, have they tried to give up and how have they got along with that? And same with alcohol. Recreational drugs, ask if they take any injectables, if they share any needles, as this can cause disease. Determine whether your patient has a good diet or exercises. Ask about their home situation to ensure that there's no evidence of any difficulties that may require interventions. In particular, if there's any abuse or domestic or sexual issues, then this can be addressed. Travel history is relevant, particularly for infectious diseases, as well as venous thromboembolic disease, particularly long-haul flights. A sexual history medically is very important and needs to be ascertained very sensitively. In particular, the number of partners, whether the partners are male, female, or both, and whether the patient has any consequences, discharges, or abnormalities. In some cases, explore wider issues such as a resuscitation status, ceilings of care that you can set for the patient, and whether the patient has transport, packages, or any other concerns that they have in their minds. When completing the history, thank the patient, summarize the key findings, and ask them if there's anything else they would like to mention or discuss, and explain the next steps to them about what you will do so they know what's going to happen next. Thank you for attending this medicine masterclass.